Good afternoon, I'm Julie Williams. I'm Director of Clinical Services, and today what we're basically going to talk about is the early detection of sepsis in the ED. We know that sepsis can be often difficult to identify. Sorry, let me turn my page there. It's often difficult to identify this medical condition due to the signs and symptoms because it mimics other conditions. So when patients present to the emergency room with sepsis, they have several signs and symptoms that'll go on. It's not like whenever they present to the emergency room with a stroke, which you can see the physical symptoms with that, or if they present with signs and symptoms of heart attack, which is very easily detectable when you do an EKG. You have the ST elevation and you start moving with stuff. With sepsis, sometimes with these subtle symptoms that they have, we have a little bit of a delay with treating our patients. And some of these symptoms, they can include your fever, chills, altered white blood count, low blood sugar, elevated heart rate, decreased urine output, your mental status can be altered, and your skin can just be mottled, and then of course you have your low blood pressure. Well, these symptoms can also mimic just your common flu. So a lot of times when patients present to the ER, they may not be treated as quickly as what you'd want them to, so you may have a little delay in treatment. So why do we want to focus on sepsis? Because sepsis has been found that is one of the 10 leading causes of death worldwide. Although we've known about sepsis for really since Socrates and over 2,000 years ago, we still have an 8.7% annually sepsis. The diagnosis is still increasing, so we're not really understanding the purpose of this. We know that sepsis kills a patient every 2.5 minutes. And when doing this research, that was just quite astounding to me to know that we allow this type of infection to kill someone. Mortality rate increases 7.6% for every hour of delayed antibiotic treatment. So therefore, when the patient presents to the ER and they have those symptoms that we were talking about earlier, we delay that treatment, that patient's risk for death increases 7.6%. And in case, just to go back a little bit, sepsis is basically a blood-borne infection, and it affects organ to organ. So once it starts affecting one organ, if it's not properly treated, it will continue to affect another organ, and it can be basically detrimental. Even once you treat the patient survives this, they can have lifelong disabilities with this. And again, like I said, sepsis remains one of the most deadly conditions. When I was doing research on this, even in the United States, we still have 1.6 million people that die annually with heart attacks. Sepsis is still right up there with that top 10. And all basically what we're wanting to do is recognize the symptoms, start the treatment, and start antibiotics quickly. But with that, we must educate. Again, like in 2007, it said that sepsis caused over 34,000 deaths. Well, if you go back a step, and it says that has increased 8.7% every year. When you do the calculations on that, this could be up to 65,000 deaths a year just based on sepsis, which is basically very astounding with that, knowing that, again, like I said, heart attacks and strokes combined are just above that. The mortality rate has remained virtually unchanged in the last several decades, ranging from 23 to 43%. So patients coming in being diagnosed with sepsis due to not that early detection, and we're just sending them through, admitting them and treating them, their mortality rate has unchanged from 23 to 43%. So, the cost in sepsis for the United States is over $400 billion a year. Whenever we're working in the healthcare system, we're constantly worried about that money coming in. $400 billion a year that's costing the hospital system just for not reacting quickly with sepsis. And just so you know, with heart attacks and strokes combined, is just $312 billion a year. So actually sepsis costs the system more than what heart attacks and strokes combined. So this is why we want to focus on sepsis. So to reduce sepsis, we must identify the symptoms and we must treat it as early as possible. When you're treating sepsis, it must be recognized and treated quickly in order to decrease the mortality rate. So when those patients come in with those symptoms, we need to know basically what's caused that infection. And you can understand with sepsis, that infection can be caused from just as simple as an insect bite, urinary tract infection. It also can be, due to pneumonia or those types of things. And we do know when patients are coming to the emergency room now, they're coming sicker because they're waiting longer to come. So you do have that aspect that you're looking at, and you also have the comorbidities with the patients that are presenting. So the nurses really need to be on cue whenever they're receiving those patients in the emergency department. And like I said, research shows that early detection is the key to prevent the death with sepsis. People that can also help the emergency department are your EMTs. So when your EMTs are actually out, because we know how many patients present to the ED by EMS. These EMTs also need to be trained, and they need to know what to look for whenever they're picking these patients up. So once they recognize those symptoms, they can start that treatment for the patient. And of course, like I said, educating those nurses in the ED to let them know we've got to get it going, we've got to say what it is, we've got to communicate with one another and talk to the physicians about this patient and what we're seeing when they come in so that we can get the treatment started faster. To also help with this, research has suggested using algorithms because let's face it, sometimes when you see it and you can move right along with something, that helps trigger the nurse's mind, that also helps trigger the paramedic's mind, and we can just move right down. We know that this works because we have those algorithms whenever we're doing ACLS measures. We have those algorithms, and a lot of times, you're not doing ACLS measures all the time. It's great to have those algorithms. So research has developed algorithms to use to help recognize sepsis and treatment. An example of a sepsis screening tool, this right here is actually great for paramedics because when the patient is being picked up, they can ask, is the patient having pneumonia? Do they have a urinary tract infection? Is it pain? Those types of stuff that they're looking for. And then they're looking at their vital signs. Do they have an elevated temp? Are their respirations greater than 20? Are their heart rate greater than 90? If their blood pressure, if it's low? Those kinds of things can kind of trigger the mind of the paramedic. Hey, what am I looking for? And then they can kind of ask the patients even more questions. And if they suspect sepsis, they can go ahead and start treatment. And honestly, then when you're going down for this and you're seeing the different treatments that you can do, you immediately want to start that bolus of fluids, basically 250 milliliters an hour. You want to pump it through that patient and also give that patient some oxygen. And usually with that, whenever you're pumping those patients full of fluids, that's usually your biggest thing that scares your clinician. If you pick up that elderly patient, and they have some history behind them, and there you are pumping them full of fluids, that can be very scary because your first thing is, I'm going to put them in fluid overload. But you got to outweigh your measures. Fluid overload versus patient dying of infection. So you want to get those treatments started early. Another algorithm that we can use that's great for the nursing, you can basically have your algorithm that starts, what is the core temperature of this patient? Are they having an elevated temperature? If they are, let's move down to the next step. If not, we're going to stop. But if they have the elevated temperature, we're going to move down. And then we're going to ask other questions. Does the patient have altered mental status? Is their heart rate greater than 90? What is their O2 sat on room air? What are their blood sugars? We want to keep going on. If we're getting yeses on this, then we want to continue down to go to the next algorithm. And with this, like I said, when you're seeing your patient with these symptoms, then what we want to do is we want to recognize these symptoms, and again, we want to communicate to one another. We want to communicate to the physician, let the physician know, hey, we've got this going on with our patient. We need to get moving. We need to do something to this patient versus kind of just sitting around waiting for the physician to come, waiting for labs to come. We need to start getting this going and starting our treatment. Just to go back just a little bit of clinical needs. Actually, in 2002, there was a Surviving Sepsis campaign published, and actually, this is when we really began noticing that, we've got to do something about sepsis. So they actually began a campaign, and they gave 17 recommendations. 3 of the most important recommendations are prompt ordering of culture. So when we get that patient, we want to go ahead and we've noticed these signs and symptoms of that patient. We want to get those blood cultures, and we want to start some antibiotics on that patient. And another thing, like I said earlier, we want to start that fluids. And of course, always, anytime a patient's in the hospital, we want to do that DVT prophylaxis because let's face it, the patient's fixing to be really sick and they're fixing to be bed bound. So we want to start those 3 recommendations. There was a hospital in New Mexico that adopted these guidelines, and they noticed a decrease of their sepsis patient and then also increased their survival rate with these patients. And basically what they did, they bundled it, and they have a 3-hour resuscitation window that they use for the 6-hour septic shock period. And what they were doing, they were measuring lactic acid levels, which has been proven to show that the patient is, a diagnosis of sepsis. You get those lactic acid levels. You want to obtain those blood cultures again, start those antibiotics, and again, like I said, you want to start those IV antibiotics. I mean, not IV, I'm sorry, the IV fluids. And again, those IV fluids, when you're bolusing that patient, you can bolus that patient up to 2,500 milliliters of fluid. And again, when you've got that elderly patient coming in, and you're bolusing that much, the first thing you're thinking is, I'm fixing to put this patient in fluid overload. But again, there's other measures for that, and that's also why they're going to start that central venous pressure monitoring whenever you get that patient to the ICU area. So we won't worry as much about that. I know working in the ED and listening to some of these nurses, that's their first thing is, why are we pumping this much fluid? We've got to pump that fluid. We've got to get it through that patient so we can flush out their system. This right here is basically a little window they come with that basically says that what needs to be completed within 6 hours. So again, you're getting that patient you're getting that diagnosis from the emergency department, you're getting that patient to the ICU area, and you're starting that CVP monitoring because they've been bolused with all those fluids. You're also going to measure your oxygen saturation throughout the time, and you're going to begin those vasopressors for the hypertension that they have, okay? And then also, you're going to have some fluctuations with your blood pressure because of the tremendous amount of fluids that you're pumping in these patients. And then of course you want to continue to remeasure the lactic acids to see if there's improvement of the patient. And then you'll have your target resuscitation guidelines of CVP. You want to keep those normalized and keep those measured while your patient's in the ICU area. To continue improvement, research suggests that hospitals use a sepsis screening tool by ambulance practitioners. Of course, you've seen that screening tool that I provided earlier. You're going to ask those patients, what's the history of them, if they've got pneumonia, any cold symptoms, or any infections, urinary tract infections. You're going to get those started. Because you're going to say that 40 to 80% of septic patients are transported to the hospital by ambulance. That's a huge amount. And again, like I said, because sepsis can be so mild and mimic other diagnoses, you really want your paramedics to know the symptoms and be educated on what to look for so they'll start these treatments. And then it was also showing that between 43 to 75% of patients transported by ambulance were identified with sepsis using the tools. So we know that these tools will help. So we need to make sure that we're educating our paramedics out there what to look for. Another thing that would help continue improvement is basically, like I said, you got to help us nurses out. We need some help. So we like those algorithms. And we're all in the EMR system, and everybody feels like the EMR slows us down. So therefore, we need to make sure that we have alert systems placed in our EMR so that, it triggers us. Hey, is the patient, does the patient have an elevated temperature? Does the patient have elevated white count? These things can trigger, and that kind of helps. This also helps in the area of the emergency department, but if you continue researching, you'll also notice that those patients that are already admitted, if we have these steps in place for these system alerts within the EMR system, that the patient already admitted who developed sepsis, if we have that EMR triggering things, and we know when that patient's respirations or their vital signs start increasing, their white counts start increasing, if we have those triggered, then it goes to certain people, and then we can also help, people like infection prevention can also help the nurse say, hey, we need to look out for this patient. And again, like I said, that education can help the practitioners be aware we can help treat the sepsis. Basically, to summarize this, sepsis must be identified as quickly as possible in order to reduce the mortality rate. We can use the bundles. We can also use the algorithms that we've shown to help with this success. And again, like I said, this is just amazing to me. Every hour of delayed antibiotic mortality rates increased by 7.6%. That's just something, because how many times does that patient stay in the emergency department before they're moved to the floor for treatment? Every hour, their rate increases 7.6. So educating that staff to recognize those signs and also really communicate to the physician so we can get these treatments started is just a key in what we need to do. And then of course, as us practitioners, we need to recognize the signs. We need to be effective communicators between our peers and to our providers. Again, we've got to be sure that we're reporting to one another and to our providers what is going on with our patients. We need to assess for signs of organ dysfunction. We need to know when these organs are starting to fail or starting, the respiration are increasing, the urine output's decreasing. These, body functions are letting us know, hey, something's wrong with me. So we need to make sure that we educate our staff to recognize these symptoms. We need to make sure that we educate to use the comprehensive sepsis treatment by using those protocols and educate and utilize them. We also need to provide patient care and family support to those involved. And again, just as being hospital employees, we know that we can prevent this by washing our hands, by doing oral care with the patient, by properly positioning the patient so they don't get wound infections, so we don't want them to get those bed sores. Do skin care, so we want to make sure we're bathing and we're looking at these patients to see if there's any types of skin breakdown. Catheter care, you want to make sure that you're doing good cath care at least daily on these patients. And then of course, if the patient does have a wound, we want to make sure that we're effectively treating that wound so that it doesn't get any worse and then it turns into sepsis. And remember, it takes a team to recognize and quickly begin treatment of sepsis. So it takes all of us to make this work. Any questions? All right. Thank you. Thank you.